right. Well, welcome everybody. It's such a pleasure to be here, and I want to thank Lynn for inviting me to come and to speak with you all. This is a subject that is near and dear to my heart, especially in the last few years, as I have begun to experience these symptoms myself. And but I have always firmly believed that there are women's health related topics that just don't get discussed enough, and that the average primary care physician doesn't learn enough about to really be useful to you all. And so one of our missions with Miss Medicine is to raise the bar on women's health around the country. And one of our primary missions is to offer evidence-based care and to train other physicians. We have a whole consortium of educators who are involved in training other practitioners to learn how to do this as well. And I think education is the name of the game. Listening, understanding, educating. And that's hopefully we'll get some of that done today. So what I'd like to cover, first of all, just to let you know, I have a medical practice here in the area. It's in Merrifield, Fairfax, close to Fairfax Hospital. I'm affiliated with Fairfax Hospital. I'm in their Department of Medicine and I'm in the service line. But I own and operate my own independent practice, so I get to have my cake and eat it too. It's wonderful. I love it. It's a new practice. I opened it about coming up on 2 years ago. And so I'm accepting new patients. I think it's a holistic approach to medicine. It's a membership type practice. And it includes time with a dietitian and a functional fitness test with a physical therapist, and it's all of the primary care that you receive is readily available and accessible to you. So small practice, very personable people, good information. A lot of people have been drawn to this model, particularly during COVID. So, all right, so what I would like to cover today in the time that we have is to learn to define menopause, to recognize the symptoms of menopause, and to help you to understand what some non-prescription therapies might look like for the symptoms of menopause, and then when and which medicines might be helpful as you go through the menopause transition. And then at the very end, I might say a little bit just about some other things to be thinking about as far as your body is concerned in this stage of life. So, I love this slide because to me, this is a group of women bonding and sharing stories and talking. And I put it in here specifically because I truly believe that menopause is not discussed enough. I think that we go through our lives, we sit in on meetings, we break into sweats in the middle of a conversation with somebody. Nobody says anything. And it shouldn't be stigmatized. Menopause is menopause. My teenager girls talk about getting their periods in a very different way from what my generation did when we were in that stage of life. And I think we as middle-aged women need to start to do that with menopause as well. It should be a topic of conversation. Everybody should understand what menopause is, especially our spouses and our close family members who are experiencing some of the from menopause, right? So I just want to encourage everybody to keep it front and center and remember that it can be something that is a really good topic of conversation. Not only that, but if you find your people to talk to, whether it's your college roommate or your sister or whoever it is, to talk about what you're experiencing, you'll find how very close to universal this experience is. So what is menopause? Menopause is clearly defined as 12 months without a menstrual cycle. So the formal first day of menopause is that day 1 full year after your last period. The average age of menopause at this time is 51.4 years. It's been somewhere between 48 and 50 since the Stone Ages. I'm not sure how they know that, but they do. And The interesting thing is that for many, many years, life expectancy didn't go much beyond that. So now we understand that we potentially will be spending 30-40% of our lives in this state of menopause. So it's important to understand what it is, how it works, how it affects you, and how to manage it. Let's see, premature menopause is defined as the cessation of periods before age 40. That's managed a little differently. The upper age of menopause is somewhere around 57. The oldest patient I've ever had starting the menopause process was at about age 57, 58. But it can start much earlier than that, with the average of the first symptoms beginning somewhere around age 45. Symptoms can last on average 4 or 5 years, sometimes up to 12 years. 25% of women do not experience hot flashes and some of the really serious symptoms of menopause. They're the lucky ones. 75% do, and a very unfortunate 2% of that group can have these symptoms, specifically hot flashes, ongoing for the rest of their lives. So, all right. So I've included a list of menopause symptoms. You could pretty much write anything on this list and it would be included. The most significant ones are hot flashes, night sweats, irregular periods, loss of libido, vaginal dryness, mood swings, hair changes, sleep disorders, difficulty concentrating, depression, anxiety, all very, very common at this stage of life. Okay. The number one most bothersome symptom is, what do you think it is? Hot flashes. Yes. And what is a hot flash exactly? Has anybody in this room experienced a hot flash? Hot flashes are redness and tingling of the skin and a sense of warmth that starts at about chest level and moves up to the top of your head. It can be associated with sweating. It can be associated with a rapid heart rate. It typically lasts anywhere from 30 seconds to 5 minutes before it's finished. And they tend to occur more commonly at night, although they certainly can happen during the daytime as well. What causes hot flashes? Well, we don't actually know the exact pathophysiology of hot flashes. It's clearly related to changes in the brain's thermoregulatory system, and which controls heat production and heat loss. And it is definitely sensitive to hormonal influence. So the primary reason that people develop hot flashes is estrogen withdrawal. Their level of estrogen drops as they go through menopause. For a few years, it's up and down and up and down and up and down before that ovarian failure really kicks in and you're just not producing as much estrogen as you did at one time. And it's that withdrawal that's the trigger for it. We know that hot flashes are worse when people carry extra weight, when they're obese. The hot flashes tend to be worse. We also know that there seems to be an ethnic preponderance of hot flashes. Some ethnic groups struggle more with hot flashes than others. So African Americans, Hispanics, Caucasians, and then the least affected typically are Asian women. So, but that, of course, in today's day and age, shuffles and changes as our population shifts and changes too. So one thing I want to point out about hot flashes, by and large, they're relatively harmless in and of themselves. They're not hurting you physiologically, but they are associated in people who have persistent and severe hot flashes. They are associated with increased cardiovascular risk. So one of the things that changes when people reach midlife is that the focus really turns from gynecologic cancers, those types of major problems that younger women have, into really looking at what we need to do to prevent cardiovascular problems. 1 in 3 women will die of heart disease, far more than from any and every type of cancer put together. And we are now starting to understand that there are risk factors that are specific to women about heart disease that we can pay attention to. For example, women who have experienced preeclampsia with pregnancy, very high blood pressure, protein in the urine, those types of problems are at much higher cardiovascular risk down the road. And the same appears to be the case with women who have persistent severe hot flashes. And by that they mean, more than a fourth of the time in follow-up discussions with their healthcare provider, they're mentioning that they're continuing to have hot flashes on an ongoing basis. And it's basically 6 days out of the last 2-week stretch of time is considered significant. Enough on hot flashes for the moment. I'm going to talk about treatments a little bit later. I also wanted to focus in people's attention on perhaps the next biggest issue with menopause, which is vaginal atrophy and vaginal dryness and urinary tract systems. A lot of people notice that things change a lot for them as they go through menopause. And these are called the genitourinary syndrome of menopause, or GSM for short. And GSM is finally coming into the common dialect now, where people are starting to know what we're talking about when we say GSM. And so this is an area that almost every postmenopausal woman is going to deal with at some point or another. In some of the circles that I travel in, people truly believe that every 50-year-old woman and up should be on treatment and management for some of this vaginal dryness, not just because of its implications on sexual activity, but also because of the problems that arise with infection and with urinary tract problems, leakage, problems with vaginal prolapse, recurring urinary tract infections, etc. So it's a very real issue. And I just finished attending the North American Menopause Society annual meeting, which was right here in DC this year. And it was a 3-day meeting, which was fabulous. But one of the things, a very funny slide was, okay, if men experienced vaginal dryness, how many treatments do you think there would be? And what do you think the cost would be? And the answer would be this many treatments and no cost. Because people just don't realize how much of a barrier this is to leading the lives that are important to us, and what would be considered a normal life. In the perimenopausal period, which is the couple of years before cessation of menses, a lot of women will begin to experience irregular periods. 90% of women will have 4 to 8 years of menstrual cycle changes. At first, it might be that the length of time in between the periods is getting longer. Then it might be that the periods are getting particularly heavy or unpredictable, might come on suddenly and be problematic if you're not prepared for very heavy flow, etc. Typically, this is because that the ovary just isn't releasing an egg every single month the way it did in prior decades. And so that endometrial lining will build up, and then it has to shed at some point, and sometimes it's more than 1 month's worth of shedding. Your doctor will evaluate you if you have irregular periods or spotting and bleeding in between cycles, or just very erratic cycles. Your doctor's going to want to evaluate you, and that is an important process just to make sure that there isn't a pathologic reason that could be very harmful to a person for why that's happening. So, another big symptom that people experience is loss of libido or sex drive. Very, very common for women in this phase of life to really slow down on their interest in sex. And this is felt to be hormonal as well on some level, but it's also complicated by some of the other symptoms of menopause. When it hurts to have sex, your libido is going to go down. So if we can, and if mood swings and sudden bursts of rage it's just harder to have a calmer or more intimate experience with your partner. So by managing some of those other symptoms, that can also help with management of libido. Very low libido is another separate medical complication, and there is actually an extensive workup and treatment strategy available for that. So if that's something that you find yourself that's really a problem in your life, then talk to somebody about it, because there is help available. I love this slide.
Me too.
Can you guys see my
That's what she's okay.
I just irritable person saying, I have not slept well. Why ask? Insomnia is a true hallmark of the process of menopause, and for many women, this is absolutely the worst symptom because it disrupts everything about their lives. They're tired, they're grumpy, they can't remember anything, they're just impact. Their mental processing is slowed down. Not enough sleep is a real detriment to how we live. And fortunately, our culture is pretty interested in sleep right now, so we're learning a lot about what happens to people who aren't sleeping enough. So, but it is definitely a symptom of menopause, and definitely there are strategies to manage it. Memory changes is another one. This one I love too. You all remember Dory? So it says, myself an email so I don't forget. So people call this memory process that happens around menopause brain fog. And that's right, it is. You just feel sort of like you're going through mud. Like things just your brain doesn't process the way it always has before. And so estrogen can definitely play a role in attention, mood, language, and memory. And it's common to experience lapses in memory and concentration during this period of time. Your working memory is that ability to assimilate new information and turn it into something productive. That's also significantly impacted at this time. The good news is that it's not always permanent, so hang in there. Mood swings, we're all pretty familiar with what mood swings are. The formal definition is a sudden or intense change in emotional state. During a mood swing, a person can quickly switch from feeling happy and upbeat to feeling sad, irritable, and angry. My main thing to point out just with mood swings is, first of all, be kind. Tell your family what's going on. Let them know if you're having a rough day and that mood swings might be a part of this day. And then also talk to your doctor about it, because it's really important to separate out mood swings around the time of menopause from a true depression. And, your doctor really should ask, have you ever had problems with extreme periods of sadness before? Have you ever had thoughts about harming yourself? Do you find it really difficult to get out of bed and function some days? Do you have periods of crying jags for no good reason? And these are, if it's an ongoing pattern, then that really should be looked at a little more closely, because there's help available. Walking around with low levels of depression or even major depression for long periods of time, it just makes life very difficult. And there are ways to manage them. So, okay.
Yeah, I can't. I just got a message that the screen's not changing for them at home. Uh-oh. You guys at home, is the screen changing now, or did I just fix it, or no? The screen hasn't been changing.
No, it has not.
I don't know why that's how. Does anyone know about PowerPoint and about Ellen? You do, don't you?
We use Teams at work, but what happens sometimes is they just take the presentation down and put it back up, and that sometimes.
I am so sorry, everybody. Can we pause for just a second? And I'm going to try to do that. I just got a chat that the screen's not changing. So I'm going to try that for just a sec. Let me stop it. I'm so sorry. All right, let's try again. I know, seriously. If anyone needs to take a break, grab some water or anything, right now might be a good time.
If you told me that I'd be practicing medicine in 2020 through a computer, I would laugh at you. It's not practicing medicine. We've figured it out.
I know, seriously.
I agree, yeah. So sometimes it's kind of nice. It's awfully nice.
Take their computers into the kitchen.
That's right.
The refrigerator, we talk about what's in there.
What is that supplement that you're taking? Let me go check. Yeah.
What about now? Are you seeing a different screen?
Yeah, we've got Dory now.
Yep. Okay.
Yes.
Okay. Now who do you have? Mood swings?
Yes.
Yay. Okay. Well, I want to go back and show you some of the funny. Did you see that one? Now you need to laugh. Okay. Okay. I am so sorry I just saw that chat. Whoever said, thank you, Nicole, for that little laugh emoji. Okay. So now we're going on to, what do you see? Cartoon?
Yes.
Okay. All right.
Translates through the thing. I'm usually looking at a screen behind, but we'll figure this out. It's a cartoon of a woman and her partner, and she's saying hot flash, and she's taking off a layer of clothing, and she's sitting on the couch, and she says, "You have no idea how hard it is to live with menopause," and her partner says, "Don't I?" And I think it's just a reminder that we really need to pay attention to the people around us, because it really does affect them too. Okay, so let's talk about some of the therapies and treatment options that might be out there for managing menopause. There are a whole host of non-medication solutions, and honestly, that's the first place to start. And in many situations, the non-medication treatments are really a great way to manage things, keep them under good control. So I put this at the top of the list because I feel so strongly about this as an internist. If you are a smoker, please consider stopping. Smoking is by far one of the most detrimental habits we have. And as you age, it will continue to cause more and more problems with time. So we know that people who smoke have more intense and more frequent symptoms of menopause. And we also know that cardiovascular risk is dramatically higher in women who smoke. So exercise can be a wonderful solution for lots of things. It doesn't necessarily reduce the intensity of hot flashes directly, but what it does do is allow people to relax. It generates more endorphins. It helps with some of the mood changes and irritability that come along with menopause. And it helps to not lose lots of muscle mass, which is unfortunately another problem that we see as our sex hormones decline. We lose muscle mass faster. It's harder to maintain muscle mass. And so exercise is a great strategy and one of the most important ways to do that. You want to do everything you can to maintain a normal body weight, knowing full well that the average menopausal woman is going to gain some weight. So it's really the right time to be thoughtful and careful about what your habits are. With food, I have sort of the same basic philosophy about food, which is the best diet is one that contains lots of fruits and vegetables, lean protein sources, healthy fats, and very little processed food and very little sugar. The average American diet has us sipping on sugary drinks most of the day and has us consuming sugar on a scheduled basis 2, 3, 4 times a day in a typical American diet. we need to cut that back and get to the point where we're eating sugar 2 or 3 times a week. So that's a real challenge, but just that one change alone can cut your symptoms in half. So that's something to pay attention to, okay? Also, you want to avoid excessive caffeine and alcohol because we know that caffeine can impact sleep and impact mood and impact anxiety levels. We also know that alcohol has a host of problems associated with it when consumed regularly in larger than just kind of basic levels. So more than 3 alcoholic beverages a week is associated with an increased risk of breast cancer. It's a relative risk of 1.4, which is the same as the relative risk of taking hormone therapy after menopause, or the same relative risk of having a body mass index over 30. So it does contribute to risk for people. Not to mention all the calories, etc., that come along with it. When you're having a hot flash, one of the keys is to dress in layers, so you can take off a layer and put it back on layer if you need it. Also to think about things like having a fan handy. A lot of people really find that the fan, being able to blow cool air on themselves in the midst of a hot flash makes a big difference, and it actually helps to get you through it faster. Another one that may, some people talk about running their wrists under cool water as a way to kind of lower that overall sensation of heat. So, okay.
Oh, great. Now it's not. There we go.
Oh, there we go. Mind body practices, which I am going to leave to these other ladies for the rest of the afternoon to tell you all about. Absolutely helpful, beneficial in many ways, if not just for the centering process and the acceptance of this process of going through menopause, but also for actual relief of symptoms. So I applaud you all for being here. I'm excited to hear what you're going to say too. For reducing insomnia specifically, some of the tips and tricks that they talk about if you're having trouble with sleep are to hold off on exercise for about 2 hours before bedtime. The same thing would go true for reducing screen time. Not looking at screens and all that blue light and fluorescence can really wreak havoc with your diurnal cycle, your day and night body signals about for sleep. One thing that is actually people who are having a lot of problems find might be very useful is actually to keep all electronics out of the bedroom. Just save the bedroom as your space where you sleep, you relax, you have time with your honey, and that's what the bedroom is for. As opposed to reading digital, scrolling through email. How many of you have had that experience where I'll just check one more time and take a peek at my email and then get an email and you can't go to sleep for an hour because there's something frustrating in the email or it reminds you of something you have to do that you haven't done yet. So staying clear of that can really help with the process of falling asleep and having more restful sleep. The ideal sleep temperature is about 65 degrees. So a cool, dark bedroom is the way to go. Remember also, as much as we love those pets, they can contribute to interrupted sleep at night. A lot of people don't even think of that. Why am I so tired all the time? Oh, maybe it has something to do with the fact that the dogs suddenly become afraid of lightning, or there are, the more creatures in your space when you're sleeping, the less likely you are to have a full night of restful sleep. Trying meditation before bed, whatever your relaxation strategy is, as you're winding down and getting ready for sleep can be very, very helpful.
You said warm milk.
And believe it or not, warm milk actually works. It has tryptophans in it that are released when it's brought up to a sort of medium temperature. You don't want to make it too hot because that doesn't work. But warm milk will release tryptophans, and that can help people fall off to sleep a little bit faster. There are are over-the-counter medications, lots of them for sleep. The data on most of those really isn't terribly robust. A little bit of melatonin can be helpful. I would advise against a lot of melatonin because, I would say 1 to 3 milligrams max if you just feel you just can't sleep and you want to have something to help you really be good the next day. But when you get up into the 10 milligram range, which is often what they use for people with jet lag, you actually have a reverse, you have a negative feedback loop with the pituitary gland and the hormones for estrogen and progesterone. So you will actually potentially make hot flashes worse at the higher doses. So beware of melatonin. It's a fickle friend. There are lots of other sleep aids out there on the market. I don't know. I'm not convinced how many of them are really helpful. I know even the prescription medications that we have are of dubious quality sometimes. Ambien brought the average night of sleep up from 5.5 to 6 hours, and that's how they won FDA approval for that medication. And they can be, the stronger they are, the more they become associated with other detrimental problems, like getting up in the middle of the night and falling, and hurting yourself, or memory lapses. So, the best strategy is the same for everything, right? Do as much as you can at home with a healthy lifestyle. When it's just not working, then let's start talking about some other strategies that are out there. Managing memory changes. One of the things to help with the aging brain is to keep active, start a new habit, a new hobby, pick up a new instrument, try to learn a new language. It's not too late, and stimulating the brain, doing puzzles, crossword puzzles, Sudoku, whatever it is that you like, play memory concentration games, use it or lose it. Right? You want to use your brain and continue to stay sharp by good activity. And then rest, getting enough sleep is a huge component of dealing with some of these memory changes, as we've already mentioned. And then healthy diet. And hormone therapy actually can be beneficial early in menopause for memory lapses and memory changes. Do supplements help? After 25 years of doing this, I have become somewhat skeptical about a lot of the products that are out there on the market. I really think that the buyer beware caveat has to hold firm. The supplement industry is a multi-billion-dollar industry, so it's really good to learn as much as you can about them. It's also very important that you really stick with where the evidence points. What does the evidence say really helps in certain situations? You're always going to have that window of time where something is new and hot and interesting and on the market, and there isn't the data yet to support it. So that's where that 5-6 year window, while they're trying to get the data, is when people go out and spend lots of money, and it's not necessarily to your advantage. So there is limited evidence to support black cohosh as far as supplements for the menopause time frame, and limited evidence to support phytoestrogens. You have to keep in mind with phytoestrogens, you have to take pretty high doses to have any significant impact. And then I always start to wonder if it's that super therapeutic, like it's that much more than you would be able to consume in a day. Long term, is that good for you? So there are, the data is really shaky. And what we always learn going through medical school, which I think is probably too simplified, but if you're spending more than $25 a year on supplements, it might be too much. So, some of these things are worth exploring. Some people find that there really is a benefit. For some of the supplements that were in widespread use 10, 20, 30 years ago, now they've done the studies, and unfortunately the impact is no better than placebo. And these include things like evening primrose oil, vitamin E for menopause symptoms, wild yam creams for the progestin component, red clover. Sadly, the data just isn't there to support use of these products for menopause symptoms.
So nothing really works for hot flashes, really.
Most of the over-the-counter stuff is just not going to get you where you need to go. The other thing, just to say about supplements, you want to go back?
Sorry.
No, it's okay. It's just because some is good, more isn't necessarily better. And I think that's really important. You know, COVID. Stave off COVID by taking 10,000 milligrams of vitamin C every day. What's that going to do to your stomach lining? That is not a natural state. That is really difficult to accomplish. And the data isn't there to say that it works. So just use your thought process, use your thinking, look it up a little bit yourself, work through it. Try to figure out who's selling this stuff and why it's so important to them that everybody take 10,000 milligrams of vitamin C every day, right? There's you just have to be thoughtful and take all perspectives. So, okay.
Do you want to go?
Yeah, just some supplements actually are harmful. There was a very interesting study that looked at how much of the active ingredient is actually in a bottle, in a supplement bottle, because supplements are regulated differently. They're regulated by the FDA as food, not as medicine. And the bar is way lower than it is for medication management. So there was a really beautiful NIH study that looked at this. And in some products offered by some stores, as much as 40% of the bottle did not even have the active ingredient in the bottle. So again, buyer beware. Are there really good, high-quality supplements out there? I'm still working to answer that question. If you guys have good information, I'm interested to hear what you have to say. Okay. Oh, and also, if you're going to buy a supplement, look for that USP label. Are you guys familiar with what USP with the circle on around it is? It's U.S. Pharmacopoeial Convention seal, and it indicates that there's been good quality control in production. If something sounds too good to be true, they're not the police. Okay, prescription medicines. I'm not going to spend a ton of time going through these. I did include a lot of information in the handout because I want you to have it available to you should you be interested or need it.
That could be a whole nother workshop.
It could be a whole, we could spend an afternoon just talking about these. So, but I wanted to give you just a snippet of the basics. There are non-hormonal medications which absolutely help with the symptoms of hot flashes and other menopause symptoms. Clonidine is one that's a blood pressure pill that's been around forever, safe, effective, does not necessarily cause low blood pressure, but can cut hot flashes 70% for some women. And it makes you just a little sleepy, which helps you take it at bedtime. Antidepressants have been used widely and marketed widely for treatment of menopause symptoms. And there's regular strength ones, and then there are also lower strength products, which are specifically used just for the indication of hot flashes. We also have neurologic agents. One is, I call it the Swiss Army knife of medicine because it fixes migraines and it fixes peripheral neuropathy and it helps a lot of different neurologic symptoms. But gabapentin has been well established to improve symptoms from hot flashes. So, and then there are selective estrogen receptor modifiers, which are kind of like hormones, only different. And those can be very effective and beneficial too. And then the hormone-containing treatments are things like low-dose birth control pills and a progesterone-coated IUD, vaginal estrogen, oral or topical treatments, estrogen progesterone therapy. So we can dive into that at another time if you're interested. And the next 5 or 6 slides.
You just kind of went over that, yeah.
There are a bunch of them. Okay. I would just like to say that hormone therapy still remains the most effective treatment for vasomotor for moderate to severe symptoms of menopause. Hormone therapy can be a real game changer for a lot of women. It's not for everybody, but it can make a huge difference for those who are really struggling with their symptomatology. And there are a lot of ways in which the hormones can influence our physiology in a positive way. Low-dose hormone treatment is not as scary as it may have been made out to sound. There are lots of increasing data now that supports that physiologic dose replacement of hormones, basically putting your hormone levels back to where you were when you were 30, can make a huge difference in quality of life down the road. It impacts skin, it impacts nails, it impacts reduction in heart disease, it impacts memory, it can impact memory, reduction in memory changes. So I guess my takeaway from this whole thing is estrogen is not necessarily the root of all evil. It is also not the best thing ever invented. But in its 65-year history, that's the way estrogen has been treated. Fabulous, horrible, fabulous, horrible. And, we're left to pick up the pieces about what's the right answer. And my take on it is the right answer is most likely, in most of these situations, somewhere in the middle. A little bit of benefit, potentially a little bit of harm if used in the wrong situations. So there's lots more we can talk about with that, but just know that hormones are making a comeback. All right, there are a lot of misperceptions about hormone therapy. I'll let you guys read over those. But the major thing I want to point out is that there are many, many, many women out there who would benefit from low-dose hormone therapy who are not receiving it, either because they've been scared off for some reason, or because their doctor doesn't know anything about it, or because there's a lack of comfort in general with diving into the specific risk factors associated with hormone use. So, but it's my philosophy is don't throw the baby out with the bathwater. Be willing to consider it as an option. Okay, and then the hormone. There are different forms that are used. We talked a little bit about oral hormone replacement therapy. There are patches, there are vaginal rings, there are creams. Progesterone can be applied topically. It can come in a patch alongside estrogen. There are oral progesterone tablets. There are different kinds of progesterone. Now we've really swung a long way in the direction of emphasizing and prioritizing micronized progesterone over other forms of progestin. They seem to be a lot safer from the standpoint of clotting risks and other problems that we've seen with progesterone, including breast cancer risk. So it's lower with micronized progesterone. So, okay. Some people just will never be a good candidate for hormone replacement. If you have had a blood clot, if you have known cardiovascular disease already, if you have had a history of an estrogen-dependent cancer, hormones are not a good plan for you. If you have severe liver disease, if you're a smoker, hormones are going to be off the table. Vaginal treatments. Now, vaginal treatments are, there are lots of different ways to manage the vaginal symptoms of menopause. And as I said, these are much lower doses of hormones than the ones we were just talking about. My personal bias is that it's hard for me to come up with a good reason why most or all women 50 and over wouldn't be thinking about access to some of these medicines and using some of these medicines if it's significantly impacting their quality of life. There are a lot of benefits to low-dose topical hormone treatment locally, specifically in the vaginal area, in the vulvar area, working around for some of the GSM symptoms that we were talking about before. Okay. There's a list of some of the medicines that we use right now for GSM that you can look at your own.
There's a bigger copy of that too for you guys because this is hard to read. And you guys at home, again, I'm going to be sending this to you.
Vaginal laser therapy is something you might hear a lot about. It's a vaginal rejuvenation. There's a Mona Lisa. There are CO2 lasers. There are all these other treatments. The very simplified version of these vaginal laser treatments is that actually there is pretty good data to support that they help with the symptoms of vaginal atrophy. So the dryness and the burning and the tightening and the scarring and the other problems that come over time with the absence of estrogen in the vaginal area, laser therapy can actually be useful for that. You should not rely on it for what they promising the moon, which unfortunately happens a lot in our current medical environment. So, another thing that happens during the time of menopause that I just wanted to bring up, the breast changes are pretty common and typical. Breast sizes decrease. There's less estrogen stimulation of the breast tissue. Things become more fatty. The supportive connective tissue decreases. We know about that. We cannot fight gravity forever. It's a little challenging. And then the ratio of fat to fibrous tissue increases, and that makes breasts less firm but easier to evaluate to screen for breast cancer. So pluses and minuses. Okay. I always like to bring up breast cancer risk because I think there's specific breast cancer risk factors that we should be aware of. Anything basically that prolongs lifetime exposure to higher concentrations of estrogen can be problematic for breast cancer risk. But then there are all the other things that we might not necessarily think of. Obesity contributes to breast cancer risk. Alcohol intake contributes to breast cancer risk. The smoking we know about. Lack of exercise actually ups your chances of developing breast cancer. So there's a long list, and you can take a look at those things. But the basic fundamentals about staying healthy apply for breast cancer too. I always like to take a minute and talk about bone health as well. Osteoporosis is a subject near and dear to my heart. My mom's had it since she was 55, and she's pretty much broken everything at one time or another. Thankfully, she's 91. She got through all of this. But osteoporosis is often undiagnosed, and bone strength and bone health is something that you can influence in this stage of your life. The biggest drop-off in bone density occurs in the first 3 years after the start of menopause. So we want to make sure that you're getting enough calcium, enough vitamin D, enough weight-bearing exercises to keep those bones strong. Your bones remodel every 7 years. You basically grow a new set of bones, and you want that influence to stay strong by exercising tugs on the tendons, which keeps that tensile strength will keep bones strong. So you want to work to prevent falls. Exercise slows, really reduces the risk of falls, and that's a big problem for people as people age. Adequate calcium is considered in a postmenopausal woman about 1,200 milligrams a day. You want to get it through the diet as much as you can. If you can't get it through diet because the lifestyle is hectic for a period of time, or you never consume dairy products, or then supplements are okay. But the total intake of calcium in a day should never exceed 2,000 milligrams. So, okay. And then I also just like to throw in preventing colon cancer. This is a time in their life where you should just be thinking about colon cancer screening too. The recommendations for colon cancer screening have now been lowered from age 50 to age 45 for all men. So, and if you have a family member, a close family member who had colon cancer, if they were younger than 55 when they developed colon cancer, your screening starts sooner. There are lots of different ways to screen for colon cancer now. Colonoscopy is still the gold standard, but it should be a conversation that you and the doctor are having. That's something that's important to go through. this last one is just the last picture is my 3 daughters.
They're adorable.
I love them to pieces. And I love this quote, strong women, may we be them, may we know them, may we raise them. And that picture was taken a few years ago. I actually now have a college grad. My second has just started. We dropped her off at Wellesley College 3 weeks ago. And the third one is has committed to play Division I soccer at Boston University.
Wow.
She's a senior in high school. So really fun to watch this whole process evolve. And, a lot of what I do for them. So.
Thank you so much. So you guys probably have some questions. We can maybe. Oh, sorry. There's one more.
I just left my contact info in case anybody wants it.
There we go. Yeah, contact info. And again, I'm going to send this to the people at home, and you guys have that information here in the studio. And does anyone have any questions? We can take about 5-10 minutes for questions if anyone has anything they want to ask. Dr. West?
Hands went up immediately. Okay, let's start it.
So I know you mentioned that menopause is considered after a year of not having your period. I had a hysterectomy, and so I'll be 45 next week, actually. And so I've started the symptoms. I have my ovaries still, but I don't have anything else. They said that they were going to leave them so I wouldn't go into menopause, but it seems I sort of have anyway. Because I had it 2 years ago. I had a hysterectomy 2 years ago. So there's like a gray area there. That day I stopped getting my period, so.
Right, and this comes up all the time. It's a very good question. Unfortunately, women who have hysterectomies may experience menopausal symptoms a little bit earlier. There's something about the process of removal of the uterus that influences the ovaries and tends to speed up their decline. Not necessarily by a ton, but by some. And so that's a great question. I mean, you are going to have to monitor for symptoms. You're at the right age for the beginnings of some of these symptoms. You can check hormone levels. We can check an estradiol level and an FSH level, follicle-stimulating hormone. When that number shoots up, then we know that the ovaries are pumping out. Do you guys know what FSH is? Do you know how it works?
No.
It's a pituitary hormone. It's released by the brain. And it's the chemical that tells our ovaries to make more estrogen and progesterone. And when it's talking to the ovaries and nothing is happening, it makes more FSH. And so those FSH numbers go up higher and higher as you go through the menopause transition. So we don't, as a general rule, order FSH on everybody because it really doesn't help us. What we're interested in is the symptoms and the side effects, the symptoms and the treatment of the symptoms. So, but in your case, it would be very appropriate for you to say, every couple of years, maybe, do you think I'm going through menopause? Here's what I've noticed. And would it be valuable to know? But the bottom line is that there's so much variability. What really matters is what are the symptoms.
Thank you.
Sure. Okay, you had one too.
Yeah, I was noticing you were saying that there are topical treatments that have estrogen in them for the vaginal dryness, but that the estrogen doesn't necessarily have as many systemic effects.
That's right.
Can you expand on that? I've never heard of such treatments.
Yes. Oh my gosh, this is right. This is. Their topical estrogen creams tend to be at a much lower dose than the patches or the pills that people take. So it's not necessarily going to fix hot flashes, insomnia, mood swings. It will act locally on the tissues that are very significantly affected by lack of estrogen. So, and there are creams.
Can you speak up a little bit? So
Sure. There are creams, there are tablets. There are, the biggest ones, like there are gels that can be applied. And there are different components too. It's not just necessarily estrogen. They also have one that's a substance called DHEA now, which is estrogen-like. And then they have combination estrogen plus testosterone gels, very low doses of testosterone. And that combination seems to work even better than just the regular estrogen. But it's really important to manage these symptoms. People get lichen sclerosis, they get scarring, a lot more is going on down there, that can be potentially detrimental in the long run. And some of it is reversible with some of these hormone uses. Typically, they'll be applied a few times a week. Some of them are lower doses and you apply it every day after your shower or at bedtime. But they are not associated with an increased risk and the big thing everyone worries about is they hear estrogen and they think about breast cancer. But the reality is that even breast cancer survivors can use these medications now. And there's no age limit. I have a 91-year-old in my practice who keeps away from recurring urinary tract infections with the use of a little bit of this estrogen.
Wow.
Yeah.
And it's a prescription.
It is a prescription. All estrogen-based products are prescriptions, so you do need to talk to your healthcare provider.
And it's covered by insurance.
It is covered by insurance. There is an age limit in some insurance plans over age 65. You may have to fend for yourself. But there are ways to get around that. There are generic formulations. If you're going to use compounded, you got to make sure you're using a reputable compounding pharmacy, but sometimes the compounding prices are lower. GoodRx is a great product. Do you guys know what GoodRx is, that yellow app? If you have to pay out of pocket for a medication, you can get deep discounts on some of these medications just by using the GoodRx app. You type in the medication and the dose, and it puts that coupon, gives you a coupon that you hold up at CVS and say, I want to use GoodRx. They scan it, and you can get 40, 50, 60% off the cost of the drug. They don't file it with insurance, so it's out of insurance that way. But the overall savings is very, very good. So, what else?
Is that so? The vaginal atrophy, is that reversible, or if you start to have that, it's very disturbing?
So the question to you guys at home was, repeat that exactly. Is the vaginal atrophy reversible, or if you get it, you just screwed? Is what Becky asked.
And the response is that it is in fact reversible.
Okay.
So getting the right hormone balance in the right location can really help to fix some of those symptoms. In fact, most often it's the first line of defense for certain conditions like lichen planus or lichen sclerosis, which has a really itching and burning associated with it. A lot of symptoms in that area, and absolutely can be beneficial and helpful in any patient.
Great. Any other questions? Going twice.
Over time.
Did you have another one? That's okay. I knew you were ready.
Okay.
Actually, it's not a question, it's just a comment that I had a really hard time with the hot flashes and stuff, and I went to acupuncture, and that was amazing. It flew me right to menopause. I mean, my periods stopped abruptly, and my hot flashes subsided. So I don't know if like holistic medicine.
I think I've
it up there. Those lines.
It's very interesting. Yes, there is data to support the use of acupuncture for a wide range of conditions.
The one I did, it was Korean acupuncture. Because there's Korean and there's Chinese.
Oh, okay.
But the Korean, I mean, it stopped the hot flashes. That's how I know.
Wow.
It stopped moving forward.
That's great.
There's an acupuncturist who's really a friend of the studio. Her name's Anita Tadavarthi. She owns Empirical Grace Acupuncture, which is right across, it's where we do our outdoor classes. She's in the complex over there. And she usually has her first 2 sessions are free. So if anyone has any interest in that, let me know and I'll send you her contact information. I meant to include her card in the goodie bags, but I didn't have it.
I thought of one other thing I just wanted to mention to you. It's a podcast about the menopause process. It's called Menopause Unmuted. And I just learned about this a few days ago. Mary Jane Nimpkin is a urogynecologist at Yale University. I'm sorry, urologist. No, gynecologist at obstetrician gynecologist at Yale. And she has done this wonderful series of interviews of real women going through real menopause. And it's eye-opening and fascinating to hear people's takes on this whole experience. So she just, further supports this idea that, it's okay to talk about this. It's okay to reach out to other people. It's okay to hear their solutions for what they're feeling. It's okay to not feel great in this moment in life, and then to figure out what you're going to do about it. So, anyway, menopause unmuted. It's really good.
Yeah, that's good to know. Okay, we'll take a quick break, maybe a 5-minute break if you guys want to just go check your phones or grab some water, use the restroom, which is right there. You see it? And then we'll come back and get ready to move just a little bit.
Nice job.